Good evening, everybody, and good evening. I see I've got a few friends out there who I've long associations with. I'd like to say that they certainly taught me a bit of medicine in Cardiff, and also plenty of drinking at the rugby club to Mr. Monsell. So what am I going to talk about this evening? So I'm going to just introduce myself in a moment and tell you what I've been doing during the COVID incident. But then what I'm going to do is give you an up-to-date sit-rep as to where we are dealing with the pandemic from a national level, and then go on to discuss not how we are medically going to recover from COVID as individual patients, but actually how the NHS is planning to recover from the huge impact of the pandemic on NHS services. So for those who don't know me, my name is Professor Chris Moran. I'm an orthopaedic trauma surgeon. I do full-time trauma surgery in Nottingham at Queen's Medical Centre. And I normally do not just trauma, but actually help run the major trauma service there and still work as point leading the trauma team. However, for the last 16 months, I've taken on a very different role. From 2012 until really just now, I was the National Clinical Director for Trauma, and along with Keith Willett, helped design and then lead the major trauma system that those of you from England will know extremely well. So helped design and designate the specifications for the major trauma centres, the trauma networks, and helped lead the entire system. And I'm pleased to say that the devolved nations, Scotland, Northern Ireland, and Wales are or have moved in a very, very similar direction. However, back in January 2020, as you know, COVID hit, and I, after a month working slightly on the periphery, got seconded to NHS England as one of 3 national strategic incident directors, which is a very senior role within the entire NHS structure, helping to direct the national response, working through the regions and nationally on a daily basis with the directors of the NHS, and also providing advice to ministers and Number 10. It's been a really very interesting experience. I've learned a huge amount. But it's also been a really humbling experience. I've been away from the front line, and I've literally just in the last month, I'm pleased to say, as the pandemic has eased a bit, been able to return back to clinical practice, doing fracture clinics and operating again. So at the moment, I'm part-time working for NHS England as incident director, and then part-time working as a frontline clinician. And really, the first thing I'd like to do is to thank everybody on this call who works within the NHS or in other services for their contributions to the incredible response we've had to the pandemic. I'm certain that lots of people on this webinar have been at the front line day on day throughout the whole length of the pandemic, either working as paramedics or in A&E or on critical care or on respiratory wards. Or just as importantly, trying to maintain other emergency care services for NHS patients. You know, as we know, in my field, major trauma continued to occur throughout the pandemic. It did actually quieten down quite a lot during the first wave, but during the second and third waves, continued at a fairly steady rate. And certainly in Nottingham, we've seen a very big bounce back, and we're seeing larger numbers than normally expected in with major trauma for the time of year. So, and we anticipate that that is also going to continue. And if we do get to the 21st of June and full release of lockdown, then I suspect trauma services will be very busy for the next few weeks after that as well. So as one of my jobs, every morning we have a pan-government sit-rep, our JSAT meeting, which is attended by NHS England, where myself or one of the strategic incidents directors represents the organisation, together with other areas of government. So PHE lead it, but we also have number 10, Cabinet Office, Ministry of Defence, Ministry of Education, etc., all in the room. And the main reason for this is that so that everybody knows exactly what's going on across government. And it's a very interesting meeting to be part of. And what I thought I'd do is just give you some idea of where we are at the moment. And you'd have seen from the press that we're currently in, from a national perspective, a stable situation. We now have low-grade endemic infection in most areas. And I think we have to be realistic and recognise that this low-grade endemic infection is probably the background that we're going to have to live with within the NHS for the next few years. But we also have a small number of areas where there's some enduring epidemic infection. And from a geographical perspective, this is mainly centred along the M62 corridor in the north, sort of running from South Yorkshire across to Manchester towards Liverpool. And this area remains really one of the places of concern within the country, which will come as no news to you all from reading the press releases from government over the last few days. The ONS have estimated that we're seeing around 3,500 new cases per day in England, and that gives us a prevalence of considerably less than 1 in 1,000, which is a really good place to be. And with that, we know that the R value is just under 1, and it's very unlikely to be above 1 in the most of the country. So our national case rate at the moment is running at just above 21 cases per 100,000 population. And this is much lower than almost all European countries, but it has slightly increased over the past week. Part of the increase is the inevitable result of the relaxation of lockdown we saw in April as that works its way through the system. But you will all be aware of the concerns regarding the new variant of concern, B16172, which originated in India but has now been identified almost worldwide. The current increases that we're seeing are being driven by an uptick in cases in Northwest, in London and the east of England. But I'm pleased to say that in most areas that we're reporting an increase, this is mainly being driven by school children between the age of 10 and 16 years. It's not being driven by sixth formers, and it's not being driven by university aged people. However, there are some areas where we're seeing increases across all ages, although these are most marked in the age groups that have not yet been vaccinated. And as we've seen an increase in the new variant of concern, B16172, we are starting to see the Kent variant, which came to the fore in December, becoming less dominant around the country. Although there is quite a lot of regional variation. I can assure you that we at NHS England, but also the government at the very highest level, are watching this like an absolute hawk. I think that what you'd have read from the statements from the Secretary of State and also from the Prime Minister, I think very accurately reflects the reality of the situation. We are watching it very clearly, very closely at the moment. There is no sign of increased hospitalizations or mortality in the Northwest at the moment. We're not seeing a signal of a major issue, but everybody remains very, very concerned, and we simply do not have enough data at the moment to know exactly in which direction this is going. So I think when it always frustrates people when they hear the government saying that, you know, we're not sure exactly what's going to happen over the next couple of weeks, but this reflects the reality of the uncertainty of a pandemic and is an honest reflection of what the situation really is. And I think that over the next 2 weeks, it should become clear, I think, in which direction things are going. The other thing we hear about in our sit reps is the vaccination program. This is an incredibly good news story for the country, where we're almost, well, for a large country, we're certainly leading the world. So altogether, I think the most recent figures for the UK are that 48 million jabs have been put into arms, of which 37 million are first doses, and 21 million people have had their second dose. And what that means is that 9 in 10 people in the population, more than 70, have now received a second vaccination dose. And the statistics and the estimates from Public Health England of the impact of the vaccination programme really are stunningly impressive. PHE estimate that the programme has prevented about 1 million cases of COVID. It's probably stopped around 33,000 hospital admissions, and then gone on and prevented between 15 and 18,000 deaths, which is just a remarkably good thing to have achieved. So I'm sure, again, there'll be people on this call who've been contributing to the vaccination programme, either as volunteers or working in vaccination centres. And again, our thanks to everybody who's worked so hard on this. Just forgive me for a second. So moving on from the current situation with the pandemic, what I'd like to do now is just have a quick chat and outline the impact that the pandemic has had on NHS services. So firstly, dealing with urgent and emergency care, over the last month or so, we've been seeing increased calls to the 999 service and an increase in A&E attendances. During the first wave, attendance at A&E went down as low as 40% of normal, and we had greatly reduced admission rates. But during the second wave, for most of the country, the third wave for the Midlands and the North, in January and February, A&E attendances actually were maintained considerably higher, but were down to around 60% of normal. But admissions through A&E were around 85% of normal. And I've always interpreted that as a good sign, in that the patients who needed to get to hospital were getting to hospital either directly themselves or directed there from NHS 111 or by the 999 services. And so I think we maintained a very good level of urgent and emergency care through January and February. As the waves subsided, we've seen a gradual increase in A&E attendances, and these are now back up to around 95% of normal. But admissions are actually running at normal levels, 100%, by which I mean they're completely comparable to March, April, May 2019. So our admission rates are back to normal. During this time, we've seen the introduction of NHS 111 first, initially as a trial, and I think that has been very, very successful. And the paramedics on this call will know that we are working very, very hard to try and extend their roles in terms of primary assessment of patients and treatment, not at the roadside for many, but at the roadside, at the door side, or indoors in the house, to avoid hospital admissions that are inappropriate. Nobody ever wants to stop patients who need to be in hospital coming to hospital. So what about elective care? Well, elective care has had a really tough time over the last 12 months. Parts of elective care, particularly cancer care, have been maintained at incredibly high levels thanks to the huge efforts of NHS staff. And we've managed to prioritise cancer patients, for instance, and ensure that their therapy took place if at all possible. But for other less urgent cases, and this could be things like hip and knee replacements or cataract surgery or ENT surgery, with the inevitable focus on treating COVID, having to use critical care beds to manage COVID, there's been a huge impact on the system. And again, you would have seen these figures, which are in the public domain. The waiting lists are huge, overall now approaching 5 million and increasing at a pretty steady rate over the last few months. Of biggest concern is that a large number of lower priority cases have been delayed for a long time. And by lower priority, when we had to make decisions when the NHS was under enormous pressure, obviously the decisions were that we should save life and limb first, and that's exactly what the NHS did. But that's left a large number of patients who really have, difficult and distressing conditions. Everybody recognises how difficult it is to live with chronic pain from an arthritic hip or have permanent problems with your eyesight. But unfortunately, these patients have inevitably suffered quite long delays. And we've seen a very big build-up of patients waiting for 52 weeks for a year or more for surgery. Although I'm really pleased to say that although we are in a bad position, actually we still are nowhere near the number of 52-week wait patients we had back in August 2007, where we had almost 580,000 patients waiting for over a year. So what's happened is the NHS was in a difficult position with waiting lists back there. We've worked extremely hard over the last 14 years to bring those waiting lists right down. But unfortunately, as a result of the pandemic, we're now left with a large number of patients waiting for a year or more for surgery. Most of these patients, around 70%, are within the 5 large surgical specialties: trauma and orthopedics, hip and knee replacements, that sort of thing, ENT, where unfortunately we also see children having to wait for surgery, something that distresses everybody. Ophthalmology, with particularly cataracts as the obvious one, where patients have been waiting, and then general surgery, where things like gallbladder surgery and hernia repairs, and then also gynecology. So what we face now, though, is really quite a difficult situation, and in many ways just a difficult situation for the NHS to deal with as the pandemic itself. Normal acute care within the NHS, our day-to-day work for me as a trauma surgeon, takes up around 70% of NHS capacity. Then on top of that, we need to provide normal cancer care, normal mental health care, etc. We also need to provide COVID care, and we need to be prepared to provide COVID care that's endemic, which I think is probably around the level we're at now going forward. And then we also need to provide COVID care, or be prepared to provide COVID care for surges in cases. I think that everybody recognises that at some stage in the future there will be a surge of cases forming another wave. Everybody absolutely hopes that that's going to be a very small wave, but at the moment it's really hard to predict the size and the timing of that wave. Because COVID is going to be endemic, we will need to continue with infection prevention and control to prevent spread within hospitals. That's had an incredibly positive knock-on effect in that we've seen a huge reduction in other nosocomial infections within hospital, such as big drops in MRSA and norovirus infections. But the real hard impact on the NHS is that it reduces our available beds by between 10 and 15%, depending on the layout of the hospital. The other issues we also face is that there is going to be a large bounce back of cases that have not yet been referred into the system. These will be patients who've decided not to go and see their GP and seek help because they know their GPs are really busy and working on vaccinations and looking after COVID patients. So our patients have really tried their best to protect the NHS, but that comes with the cost that within the population, we know we have a large number of patients who have not yet been referred into the system. And in some chronic conditions, such as trauma and orthopedics, those patients are inevitably going to come back, because arthritis is not a disease that goes away. It's often progressive, and it often comes as a surprising fact that actually most patients on a waiting list for a hip or knee replacement actually have a longer life expectancy than the average population. And so those patients are going to come back over the next 2 years. In addition, we also, as I've said, have this large backlog of cases with a big peak of patients who've been waiting now for over a year. And I think the other thing we need to recognise, and we need to be honest about, is that the pandemic has potentially increased health inequalities within our country. The hardest hits have been the poorest communities, and we all recognise that there has been a differential in the way COVID has impacted different ethnic groups. And so whatever happens as we recover from the pandemic, we have to make sure that we maintain and actually improve upon our access for all members of society. And one of my biggest concerns is always that people with sharp elbows can push their ways to the front of any queue. But actually the people at the front of the queue need to be the people who need the surgery most, irrespective of what their background is and how hard they push to get to the front. So what about our recovery? So early reports really show that the health service is recovering faster following the wave in January and February than after the first wave. So for the first 2 months of the year, NHS staff completed almost 2 million operations and other elective care episodes, despite at the same time providing care for almost 140,000 COVID patients. And around 2 in 5 of all COVID admissions during the entire pandemic have occurred in that January-February period. And yet somehow, and it truly is remarkable, the NHS managed to adapt and complete 2 million operations and elective care episodes. A really remarkable achievement. So for the first 3 months of 2021, we've now treated 150,000 COVID patients, and we've now admitted 2.75 million non-COVID patients. Treatment rates in January and February were 70% higher than during the height of the first wave, which I think again shows how clinicians and hospitals have adapted their services to allow remarkably high levels of care for patients with COVID, and yet continue to provide high levels of care for other patients. The other really good news is that emerging data, and this really is just coming out over the last few weeks, shows that we've already bounced back much quicker than we did after wave 1. So following wave 1, it took about 4 months for us to get up to 80% of normal activity. But following the wave in January, February, we've achieved that in just 2 months for elective surgery. And absolutely remarkably, in March, and these really are hot off the press figures, the NHS achieved 100% for outpatients. So that means a similar number of outpatients were seen in March 2021 as seen in March 2019. And that really is an amazing achievement. And that's been achieved by a combination of a complete reorganisation as to how clinics are working, in terms of face-to-face consultations, but we're also now looking at 20 to 25% of consultations occurring remotely, either on telephone or by some form of video conference. And there's no doubt, I think that's proven very popular with patients, helping with travel and the difficulties that we all recognise of parking at the hospital. And it's been particularly helpful in some areas where they have very large geographical areas where patients have had to travel for follow-up appointments, very long distances, and the ability to do those remotely, I think, is a huge benefit to the patients. I think the one thing we have learned, though, I heard very much from my clinical colleagues who have been involved in day-to-day running these clinics, is we have to recognise that a remote consultation is not a quick consultation. They take just as long, if not longer, than a face-to-face consultation because you've lost quite a lot of your non-verbal communication. And so a remote consultation is not a quick fix for the numbers we need to see, but it does have really significant advantages for patients, and particularly some specialties where it's very, very fitting to do. As we've recovered from the second wave, the initial focus through March was, as I mentioned earlier, to make sure that we're absolutely up to date with our cancer services. And so in March, a record number of almost 250,000 people with suspected cancer were seen in NHS services. And this was achieved despite, as I've said, the additional steps needed, such as infection control, to keep our patients safe. And at the same time, the NHS has been rolling out the largest vaccination programme in health service history. So I'd just like now to move on to discussing what we're doing, and I'm involved in some of this work in trying to recover our waiting lists. The waiting list, I think, for me as a clinician, it's not NHS speak, but it's my simple clinical speech, divide neatly into three types. We've got patients on a waiting list for surgery or a surgical procedure. We've got patients on waiting lists for diagnostics. That might be a endoscopy. It may be an MRI or a CT scan. A large number, probably 80% of diagnostics waiting list is for radiology services. And then finally, we've got the biggest waiting list of all, which is the outpatient waiting list, where patients are being seen by their GPs and then referred in for a specialist opinion at the hospital. As I mentioned, we've now got large numbers of patients who've been waiting a long time. I think the figure that was quoted to me that really struck a chord was from the Northwest. So at the beginning of the pandemic, just as we went into it, there were just 50 patients in the Northwest who'd waited 52 weeks or more on a waiting list for surgery. That number has now grown to 50,000 and is still growing. And there are not many things you see in medicine that grow 1,000-fold. I guess viral growth and bacterial growth. And now, sadly, we've seen that sort of change within our waiting list. And that gives you some concept of the scale of the problem that we face. And there's absolutely no doubt that there will be a huge public, media and political focus on the waiting lists, not just the large number on the waiting list, but also particularly on the poor patients who've been waiting for a very prolonged length of time. And I firmly believe that the NHS to date has been judged on our and your magnificent response to the pandemic, plus the incredible vaccination program. And there's no question that it's a massive tick from the public and the government in terms of the NHS's response. But I think we also need to recognise that in the future, we will not just be judged by that response, but we'll also be judged by how well we recover and how well we manage to catch up with these long waiting lists that we now have. And so I think it really is going to be, apart from managing ongoing surges, perhaps another new variant coming along, I think it is probably managing the waiting list has to be one of our most important targets over the next 2 to 3 years, and we have to manage it in a way as I mentioned earlier, that does not increase health inequalities in any way at all. So far, we are looking to address the waiting list in all three areas, but starting with surgery in three ways. Firstly, we need to look at our capacity, and it needs to be increased clearly. Secondly, we need to make sure that the waiting lists that we have are valid and have been validated. We've got the right patient waiting for the right operation or the right diagnostic procedure, or appropriately referred to the right clinic. And then the third thing I'm going to touch upon is something that we need to really seriously consider, and that's how we support our patients who've been waiting for long times on the waiting list. So to touch initially on how we should increase capacity, I think there's a huge drive to do this throughout the NHS, not just at NHS England, but I think that every single trust in the country is working extremely hard on this taxing and difficult issue. We clearly need to improve our efficiency and productivity. We clearly need additional investment into the system financially. We absolutely must support our staff because the NHS is its staff, and we need to increase the capacity also by using the independent sector in a very effective way. So to address some of these problems, and Simon Stevens has given a really clear indication that we need to move to managing waiting lists at a system level, by which I mean an integrated care system, usually consisting of a number of hospital trusts working in complete collaboration. And I think this is something that we've been really looking to do within the NHS for a number of years. I think the previous system of setting all trusts up into competition with each other clearly has had its day. Leave it for you to judge on how successful it's been. But we're now moving into an era of collaboration, very close collaboration between trusts, which is exactly what we've seen throughout the pandemic. I think one of the outcomes of this is likely to be the development of surgical hubs. These hubs will focus on a single specialty and focus on the high volume, low complexity work, so that because that makes up the vast majority of the patients who are waiting prolonged periods of time for procedures. Although as a surgeon, I'd just quite like to point out to the audience that the high volume bit is correct, but the low complexity is a little bit of a misnomer. I don't think that anybody really believes that doing a hip replacement accurately is a low complexity, easy operation. It's an extremely skilled and difficult procedure, but what it does need is to be done exactly the same way, repeatedly, time and time again, to give the best outcomes. And concentrating these cases into a surgical hub, which will allow a standardized pathway of care for the patients, reducing their risks to a minimum, and allowing high quality surgery in a timely fashion is going to be the absolute aim of that. Obviously, we can't just do the high volume work. We also need to do the low volume, high complexity work. And we're also going to need to think about how we're going to manage those within a system. Because one of the common features of the high complexity work is a high reliance on critical care units, and surgical hubs aren't going to have those to the level that might be necessary for major cardiac surgery or major spinal surgery or major ear, nose and throat surgery. And so we do need to work out how we're going to address that deal of work as well. Clearly, this needs government investment. So far, as a starter, the government have provided 1 billion as for the elective recovery fund. And I think it's very important that we use that money wisely. But it seems inevitable that further investment in the NHS is going to be needed to address these long waits. And as I touched upon earlier, it's important to say that our workforce is absolutely key to this. There's no doubt that many of our colleagues have had a really tough time over the last 12 to 16 months. And there's some people who really need a rest and a break. I'm absolutely certain that everybody on this call and everybody I know needs a holiday, and we're all looking forward to that. But the other thing that really clearly come back to, I've really loved going back into my clinical practice and doing what I do best. And actually, I really see people around me who actually want to get back to some form of normality. And that does mean for lots of us who are workaholics within the NHS, that means doing what we do best, doing what we love, getting back to treating patients in our own specialty, in our own theatres, in our own outpatients that we're used to working to, and working within the small teams that make the NHS such a great place to work. So I think that there's a really key requirement to allow people time to rest and recover. But I actually believe that part of that recovery is allowing people to get back to doing what they really love. And most people in NHS really do love their job. But beyond that, there is a clear requirement to expand the workforce, and we at NHS England, along with Health Education England, are looking at how we can rapidly develop different roles, how we can extend and expand the workforce, and how people can be upskilled into expanded roles. And I think this is something that we're going to have to work at very hard over the next 2 years. We've got many people within the NHS with fantastic potential, and we need to release that potential with enhanced training and allowing other non-medical, by which I mean non-physicianly people, to extend their roles and undertake far more diagnostic and other procedures. The other thing that we've been working at is validating the waiting list, because we need an up-to-date and valid waiting list to manage the patients properly. And so for surgery, we've undertaken a three-stage process. Firstly, an administrative process to check that everything that it says about the patient on the list is correct. Secondly, it's been followed by a notes and procedures review to check that that's all right. And then if there are issues with that, then clinical contact of the patient, if it's needed, to discuss whether they want to go ahead with the operation, to discuss whether it's an appropriate procedure. And to date, we have now validated almost 1 million patients on the surgical waiting list. But it's important to emphasize that this is an ongoing process, and we must have every trust and all clinicians must have a way of detecting or flagging deterioration in patients, because sadly we know that some patients will deteriorate whilst they're waiting, and we need to identify those patients and reprioritize them so that they can have their treatment in a timely way. And I'd just like to finish off for the last 5 to 10 minutes of my talk about something that is quite close to my heart and has really struck a chord with me. And this is supporting patients on a waiting list. And this is an interesting concept. When I became a consultant in the early 1990s, it was not uncommon, I'm sad to say, for my patients to wait 2 or even 3 years for a hip or knee replacement when I was doing those procedures. And those patients used to go off, wait patiently, and their GPs would help manage them and get them through what was a really pretty uncomfortable few years, living with their disease, often the joints slowly getting worse, until they reach their point on the waiting list. From 2007 onwards, we had a really massive improvement in the ability of the NHS to provide timely care, thanks to a lot more investment in the service and better efficiency. And we reached the stage where the majority of patients were, the vast majority of patients were just from referral to GP to completing their treatment within 18 weeks. With such a short period of time, there was really no need at that stage to actively manage the patients to a large degree. But we're now back to the future, and we've now got a huge cohort of patients who'd anticipating having their operations last March, last May, last April, have now been waiting over a year for surgery, still don't quite know when they're coming in. And I believe that we need to have a radical rethink within the health service about how we manage these patients, because I think that we need to actively support them. And the one thing that is absolutely crystal clear is that general practitioners who are working incredibly hard with dealing with A, the volume of patients they're having to see, and B, the vaccination program, general practitioners are not there in the numbers we would need to support these patients. And we're getting increasing reports from primary care that a significant proportion of the patients who they're having to see are patients who are anxious or deteriorating whilst on a waiting list and need further advice. So I think we need to move from passive to active management of patients on a waiting list. And there's been, I'm just going to just highlight some really interesting work that's just been completed at the University of Leicester. Prof. Joe Dias is a hand surgeon there, really fantastic and outstanding hand surgeon. But he's been working with members of his team who include experts in behavioral science, in psychology, and social networking. Very odd things for an orthopedic surgeon to do, you'd think. And what they've done is they've looked at 4,000 patients on the trauma and orthopedic waiting list, and then sent them a questionnaire. And they managed to achieve replies from 891, and that sample size is greater than they'd expected, and means that their work has just a 3% margin of error. And they've come up with some very, very interesting findings that I thought I'd share with you. And Joe and his team are very happy for this to be shared. So firstly, 79% of patients wanted to get on and have their treatment and their surgery despite COVID. They just wanted to get on with things. And overall, 94% of patients wanted to proceed whatever. So just a small proportion of patients, about 1 in 20, felt that because of the risks of the ongoing pandemic, they changed their minds and didn't want to have the operation, which is completely understandable. But it was also notable that about 36% of patients were very anxious about coming into hospital, and that's a higher number than we would normally see. And it's quite understandable why they would be anxious. One of the real concerns to us, though, was in terms of their pain, mood, and anxiety levels. So the patients, and this is a large number of patients, scored their pain at 6.3 out of 10, which indicates that they were suffering with moderate to severe pain on a daily basis. Their mood was moderate to low, with a score of 5.1 out of 10. But probably most concerning of all is their anxiety score was 3.9 out of 6, which meant that the average patient waiting was suffering with severe anxiety. And we all know that the living with chronic pain results, the A is debilitating, and B, it gets you down, and it results in anxiety and depression. And people are now waiting a long time, and we need to do something to try and help them. They also asked the patients what the hospital and the clinical teams had done well. And our patients were very positive about the technical solutions. They were really positive about getting texts, messages, updating them on situation and outpatient appointments, and were really positive about the ability to have remote consultations. They're also very positive that if they went to the hospital, that they felt the infection prevention and control was very visible and very effective. But there were unfortunately some areas where they felt we could do quite a lot better. And the patients who felt very much on their own felt they needed better access to doctors and to pain management. They felt that their quality of life was suffering, which is no surprise. They were on a waiting list for a good reason. And they found themselves frustrated by a lack of information about the delays and an update as to what was happening to them as an individual. And I think the other area that we need to work a little bit harder on is to look at single points of contact to allow patients easier access. And so Leicester have really worked really hard, and I think have come up with some very interesting ideas to try and help patients in this situation. They have a 3Cs concept, which is to looking at concerns, coping, and catching up, which I think is a very nice way to think about this. So I think it's really important as NHS, all NHS people, that we hear patients' concerns. We need to help patients to cope who are waiting on the waiting list. And we also need more engagement with the patients as we catch up. And I think there's a lot of practical things that NHS organisations around the country can do to help. These include self-help, directing the patients towards websites and emergency contact sites, providing remote support. Some areas are now doing group sessions as webinars for patients who've got the similar conditions like a hip or knee replacement to help them through. We need to be able to direct patients to correct specialty services. That might be physiotherapists or occupational therapists, either in the hospital or in the community. And for some patients, it may mean directing them towards mental health services or websites that allow self-help for milder mental health issues. And then finally, it's really clear that some patients are deteriorating, do need escalation to their clinician, who can then consider whether interventions or review of the priority is required. So I think there's a really clear message that we're receiving from patients is that, as wherever we are within the healthcare system, if we've got patients on a waiting list, be it for diagnostics, outpatients, or an inpatient waiting list, I think that we really do need to think hard about how we support them in what is a very, very difficult time for them. And then I think that I will probably finish with just a very brief mention of, you may have read in the press of, and you may actually be involved in the accelerator sites, which is a £160 million initiative to try and help tackle our waiting lists and develop a blueprint for our elective recovery. And so NHS England is doing this by trialling new ways of working in a dozen areas around the country, and also our 5 specialist children's hospitals. And each of these elective accelerator sites will receive a share of the £160 million with additional support to try and implement and evaluate innovative ways to increase the number of elective operations they can deliver. And so over a 12-week period, it's a really short, intensive trial. We're hoping to manage tens of thousands of patients through these services to see if we can help the system recover and benefit those patients. And so we're looking at a number of really interesting and exciting initiatives, such as high volume cataract services, one-stop testing facilities, so you go and have all your tests in a single go, easier access to GPs for specialist advice, which I'm sure will be greatly welcomed, and then further developments of virtual boards and home assessments. So I think there's exciting times ahead. I think that to summarise, we have been through the most difficult period of the NHS's lifetime since its inauguration. after the Second World War. The NHS, people out there at the front line have provided just exceptional levels of care for patients. And I've seen, my parents had COVID. I've seen the remarkable care that they received, and I'm eternally grateful for all the care and assistance that everybody has given. We've reached a stable situation with the pandemic. We are watching very closely the developments with this new variant of concern, but at the moment we're not seeing a signal, and so we're hoping we can continue with the recovery programme. The NHS is, however, facing a Herculean task to try and recover from the impact of the pandemic over the last 12 months, with an emphasis on the patients who've been waiting for prolonged periods of time. So we've got difficult times ahead, but also incredibly exciting times, a chance to innovate, a chance for us to introduce the things that make us work more efficiently, a chance to cut corners in the bureaucracy, but not cut corners in our levels of care and our levels of safety. And so I'd like to just finish by saying, on a note of optimism, and say, number one, thank you to everybody. And number two, hopefully we won't face another major wave, and that we'll be able to continue this recovery process over the next 12 to 18 months. Thank you.